we're going to have Betina Yanez speak with us about patient-centered care in oncology. So Betina Yanez is an associate professor in the Department of Medical Social Sciences at Northwestern University Feinberg School of Medicine. She's a member of the Lurie Cancer Center and director of patient engagement for the Cancer Survivorship Institute. Broadly speaking, her focus is in the area of cancer control and survivorship, and her work bridges behavioral medicine, health equity, and precision medicine to research improvements in the patient-centered and clinical outcomes of individuals diagnosed with cancer. Dr. Yanez's research program is characterized by work focused on three major public health problems facing cancer patients and survivors: adherence to cancer treatments, outcomes among racial and ethnic minority cancer survivors, and reach and scalability of evidence-based interventions for oncology patients that can be delivered via technology platforms. An emergent area of her work involves patient-centered precision oncology.
Thank you, Chris. All right, good morning. Yes, good morning, everyone. So I'll be talking about patient-centered care in oncology. I do need to disclose that my research is partially funded by BMS. Okay, so let's start with developing patient-centered care in oncology. I get that question a lot, like, what do you mean by patient-centered care versus patient-centered research? And I think they go together, and my goal here at Northwestern is really to engage stakeholders to enhance the outcomes of individuals diagnosed with cancer. So I look at symptom management, enhancing patient-provider communication, provision of information and education to our patients, enhancing access or facilitating access to care, especially among our underserved or minority patients, providing emotional support, all with the goal of providing better patient-centered care. And in order to do that, I work with activating patients and getting them involved in research studies that will hopefully improve the quality of their care here and their outcomes, working with the community as well, and working with providers. And you're gonna see samples of all of that in some of the research studies that I'm gonna talk about. So my focus is going to talk about enhancing patient education and symptom management in mostly cancer survivorship, but a little bit of cancer control as well. And two important issues facing cancer survivors that I see are health equity and survivorship. We see a lot of disparities in symptom management control, patient-reported outcomes in survivorship, and adherence to oral anti-cancer medications, which is another issue that I'm really interested in, and key approaches to improving survivorship care. So I'm going to talk about patient and community engagement in research and care and technology-assisted interventions in behavioral oncology. And you're going to see how this is all going to come together. So first this is a little bit of outline or roadmap of where we're going for today's talk. We're first going to talk about the MyGuide study, which works on engagement of diverse and minority patients in cancer research, and that's a little screenshot of the MyGuide app. And then we're going to move on to the My Journey study. I have a lot of my guide, my journey, but every time I talk to patients about what they want to call the study, they say they wanted something very personal, something for themselves, so we go with a lot of my's. And so My Journey is actually a study for patients who are survivors who are initiating endocrine therapies. And then if we have some time, I'll go on to some future directions and talk a little bit about some trials for patient engagement and symptom management for patients with advanced disease who are in active treatment. So let's talk about the MyGuide for Latina and Hispanic breast cancer survivors. I will say sometimes I talk about it in Spanish. I say mi guía because that's how we translate MyGuide in Spanish. So if I say mi guía, it's just MyGuide. This is a study for mostly Hispanic, or all Hispanic, mostly Spanish-speaking participants. So I go back and forth between calling it MyGuide and mi guía. The reason I got interested in this is because the literature has shown a documented disparity among quality of life outcomes among Hispanic breast cancer survivors, where among Hispanic women, they report poor quality of life and greater symptom burden after treatment compared to their non-Hispanic white counterparts. And this has been documented in the literature. And there's really few supportive psychosocial interventions for this patient population. And providing culturally and linguistically tailored cancer-related information is really crucial to promoting health equity among this patient population. Something I also like to point out in my talks is that cancer is not the leading cause of death for non-Hispanic whites, but it is for Hispanics. So we see that disparity as well, which is why it's, I think, incredibly important to focus on Hispanic breast cancer survivors. Having worked with this population for, I lose track now, I don't know, 15 years maybe, since grad school. Some of the barriers that I've heard women telling me anecdotally is language is a big barrier, right, to talking to their providers, to getting information, to educating themselves, to being an advocate for themselves. They feel disconnect when they go in to talk to their providers, not just maybe because of language barriers, so even if they speak English or they bring a translator, they feel a distinction between their provider, and that sometimes, you know, they have to respect their providers. They can't ask too many questions. They feel like they're in a different class, and that doesn't facilitate them getting the information that they need, asking the questions, getting enrolled into clinical trials, getting access to the services that they need. And we also see that smartphone applications, so here is the technology component, are really a viable approach to delivering supportive care interventions. So our Latina patients have been telling us that they don't have the same access to care because of many barriers to supportive care services that they need and they could benefit from in order to improve outcomes. But smartphones are ubiquitous. We all have a smartphone. I'm sure, hopefully it's on vibrate for all of us right now, or mute. And I think it's a great way to bridge care for a lot of our patients, especially patients, as Siobhan was saying, who can't come down here all the time for a supportive care visit, and where we could potentially offer something remotely or electronically. And we've seen an increasing use of Hispanics and African Americans using smartphones, not just for communication, but also to access health-related information online, and that's what the data is telling us. So this could be a great resource to deliver an intervention that could help enhance supportive care resources. So My Guide, the goal of this study was we wanted to create My Guide, or Mi Guía in Spanish. It's a culturally informed e-health intervention designed to improve the health-related quality of life, or HRQOL, and reduce symptom burden among Hispanic breast cancer survivors. And then we wanted to determine the preliminary feasibility and efficacy of My Guide, this application that we developed, compared to a control condition or a health promotion condition called My Health. So in order to develop My Guide, this is something where I think this is a great example of a study where we had multiple engagement of key stakeholders. We worked with providers, with clinicians, the community, patients, to develop this application, because I can develop an application with the best content that I think is going to be relevant to our Hispanic, Latina breast cancer survivor patients, but I am N of one, right? So we needed to get a lot of feedback and really go out to the community to get an assessment of what are our Latina breast cancer patients' needs and concerns, especially unmet needs. So we worked with a community partner, Alas Wings. Many of you, if you're in the Chicagoland area, might have heard of the Latina Association for Breast Cancer, and Judy Gudelman, who has been instrumental to the development of this application. We worked doing field interviews with patients. We engaged community partners, especially when it came to cultural and linguistic considerations of how we presented the content on symptom management and survivorship topics to Latina breast cancer patients. And then our providers really helped us a lot with clinical content and symptom management. So it was an iterative approach. So when I talk about working with the community and how I work with community-based partners, I take a community-based participatory research or community-engaged research approach of each of us, the academic partner and the community partner, bring something really important and pivotal to the table. My group will bring the specific aims and the scientific aims and goal, and I work with the community really to identify the needs in that particular community, which are going to vary. They're going to vary within the Chicagoland area. They're going to vary from Northwestern and Chicago to Miami, Los Angeles, New York, et cetera, to really come together into defining the problem and the study design and developing the partnership. And then we move on to cultural concerns and adherence to the protocol. So as a scientist, I'm very much like, we have a protocol, we have to adhere to it, and then my community-based partner comes in with like, well, let's also talk about how your protocol is going to be affected by cultural concerns, and let's talk about that and how that's going to affect data collection, analyses, participant recruitment, and then we work together to publish findings, and my community partners are always reminding me, it's not just enough to publish your findings and talk about it at Northwestern. It's also important to disseminate and go back into the community and translate this to our community members. So we work on that together in the dissemination piece. So when we developed My Guide, we first started with step one, which is doing qualitative interviews and getting feedback from patients on the linguistic and cultural adaptation of the information and how relevant this app could be for them, usability testing. We did a brief field trial of 25 participants across 4 weeks, and then we took it to a larger randomized trial of 80 participants. So lots of steps involved, and this was about 3 years of work. And what did we find? Around year 3, we had the data from the initial feasibility trial, and we actually found that the app improved significantly women's scores on breast cancer knowledge. So using the app over 4 weeks improved their breast cancer knowledge significantly. And then we saw a trend for improvement in health-related quality of life across time, but it wasn't statistically significant. Also, this is a very small sample size, 4 weeks. We weren't really powered to find significant effects, but we were just hoping to go in the right direction and get some initial data that this is an app that women would like and it could potentially make a difference in their survivorship outcomes. So based on that data, we also interviewed participants, did exit interviews to get a sense of how we can enhance the app. We then took all of that data and we enhanced My Guide. And this is, let me see if I have a pointer. Can you see that? Yeah, okay. So the left is the My Guide application that we tested in the randomized trial, and then we had to develop a comparison application. So we developed one. It's an active comparison application called My Health. And My Guide really, as you can see in the screenshot, it has information on managing emotions, symptom management, everyday support, community support, managing health, breast cancer medications, information on endocrine therapy, stress management. So it was meant to transition patients who were finishing active treatment into the survivorship topics and information that they would want to learn as they were finishing up treatment and going into survivorship. My Guide is not meant for long-term survivors. It's more like initial survivors. And our control condition, My Health, was a lifestyle intervention. So you'll see there's an apple there. It says healthy eating matters, how to eat well, exercise. So this was what we compared My Guide to. And across both platforms, so both applications are available in English and Spanish. They have tailored reinforcement messages to enhance engagement, stress management, and relaxation exercises. Survivor stories, a lot of women felt that they wanted to connect more with hearing stories from other women. Lots of local resources, educational videos on treatment side effects and coping with cancer, strategies for adhering to endocrine therapy. And we filmed some videos in English and Spanish. Both of the applications are available in English and in Spanish, and they have audio recordings, so that one of the concerns that participants would tell us is they were a little bit concerned about reading so much information and literacy and how to digest it. So we actually audio recorded all of the content in 2 languages and embedded play buttons. So anywhere in the app you can press play and listen to everything. We also gave participants headphones too, so they can just listen to the app if they were commuting or walking. That's actually what took the longest time, was doing this in 2 languages, both written content and audio recording. And that's actually our study physician. She did these great videos in English and in Spanish, so we would have parallel videos to upload into the application. The My Health had some information on recipes that were specific to Hispanic and Latin cuisine, like we talk about going to salsa classes for physical activity. So for the randomized trial, women either got My Guide or My Health across 2 months, and then we looked at symptom burden, health-related quality of life, well-being. We had a couple of other secondary outcomes, and you'll see a little step there. I talk about the stepped care protocol. So we would actually call and reach out to women who were enrolled in the trial. If we noticed that they weren't using the app a lot, we would call them. So if they weren't using an app, they got phone calls. If they were using the app a lot, they didn't get as many phone calls, and that's a stepped care protocol. And it kind of helped with my staff, because we didn't want to be calling all the participants on a weekly basis to check in, especially when some of our users we call them the super users. They were on it all the time. They didn't need to talk to us. They're like, we're good, we don't need to talk. So having that stepped care protocol and only reaching out to women who really needed that call was really helpful, especially for my research staff, who's doing a lot of work on this study. So on average, women were about between 53 and 54 years of age, which is actually, that's pretty good, and that's consistent with the average age of Latina or Hispanic breast cancer survivors diagnosed in this country. They're a little bit younger than non-Hispanic white women. And the majority of the women, I believe, participated in the study in Spanish. We had some who did it in English, but the majority preferred Spanish. And they were all non-metastatic breast cancer, and about close to 60% had chemotherapy. The majority had radiation therapy. So recruitment was really good at close to 80%. Retention was excellent and didn't differ across the study conditions. Participation, satisfaction. We asked them questions about how usable, how satisfied, would they refer this app to a friend. That was also really good. And we actually had good weekly use of both of the applications. You'll see at the bottom the average use across the first 6 weeks was about, like, let's say 87 minutes for My Guide, and about 73 minutes for My Health is what they were using it. And that was our goal. I figured if they were to come in to Northwestern to meet with somebody in supportive care, social worker, psychologist, dietitian, that might be a 45, 50 hour minute or 1 hour meeting a week. So our goal was to get them to use it for at least an hour a week, and we succeeded in that. And what did we find in terms of results? Basically, both conditions improved across time. So when it came to breast cancer symptom burden, especially between time 1 and time 2, symptom burden decreased significantly across time, and breast cancer well-being increased across time from time 1 to time 2. They liked both conditions. And we actually expected to find this, because as my staff was making calls and doing telecoaching, and as we were getting the data from the feedback at the end of the studies, we realized that participants were liking both of the conditions, so this wasn't too much of a surprise. A couple of interpretations on the finding. One is the participants who enrolled in our study to begin with actually had pretty good or average to good quality of life and symptom burden to begin with. So this wasn't a sample of patients who were particularly distressed or had the worst symptoms or the worst quality of life to begin with. So it's not like they had a lot of room for improvement. It could have just been a biased sample size. Other things that we figured out along the way, it could have been a very short study. 8 weeks is probably not long enough to see significant improvement across time, and a lot of our participants told us that they wanted to keep using the app and they felt like they weren't done, so it's possible if we extended the timeline we would see something different. What we did find, which was interesting, we had some outcomes on dietary intake, and we found that participants who were randomized to the My Health, which is actually our control or comparison condition, so those participants in My Health, their fat intake actually reduced from the study baseline to the post-intervention, but we didn't find that effect for participants who went to My Guide, because My Guide focused more on symptom management and coping, whereas My Health was lifestyle. So we had this great effect with our comparison or control condition that was a little bit unexpected. And so what we decided to do based on feedback and this data, and we got 2 more years of funding to enhance My Guide, we're actually merging both of the applications because women liked both of them, and women in My Guide kept saying, oh, well, I really liked it, but I wanted more on lifestyle. I want to know what to eat. So we get that all the time. And then women in My Health said, this was great, but I want a little bit more on coping or how to talk to friends, or like, what does depression look like? When should I talk to a doctor about that? So we merged them together, and now we're testing this new application in a new trial. The nice feature about My Guide is, and this is where the personalized part comes in, we spent a lot of time developing an algorithm to personalize My Guide to each participant. So they actually take a questionnaire at the beginning of the app, and based on their responses in that questionnaire, the app adapts. So if a participant is saying nausea, pain, fatigue, hair loss, sexual functioning are my issues or concerns, they see that first. And another patient can say it's depression and it's something else, they see that first. So the app is unique to each participant. All of the content still stays in there so they can access it, but their experience of it is going to be tailored to each participant. Now we'll move on to My Journey. This is another study that's we're working on for breast cancer survivors. I think I don't need to talk about the importance of adhering to endocrine therapies to this audience, because the majority of patients with non-metastatic breast cancer at some point are going to be prescribed an endocrine therapy, and non-adherence is problematic, and it's associated with breast cancer recurrence and mortality, and side effects of the medication is a commonly reported reason for non-adherence. So my team and I are establishing the feasibility of a mindfulness-based intervention to improve adherence, oral anti-cancer adherence, and health-related quality of life among breast cancer survivors who are recently prescribed an endocrine therapy. This is not a study just for Latina or Hispanic women. All women are eligible as long as they've been prescribed an endocrine therapy. And participants in this study, it's actually a very similar design to my guide. They're randomized either to My Journey or My Health. It comes back over 2 months. And this is actually, and then we look at adherence to endocrine therapies and health-related quality of life. So what is My Journey? It's a little bit different than my guide in that My Journey takes an approach of including a mindfulness practice. This came about because I think a lot of our patients were complaining about some of the side effects associated with endocrine therapies and the struggle to relieve some of those side effects, which is not always easy. And we felt that engaging in a mindfulness practice and teaching patients the value and utility of a mindfulness practice could actually help them cope and deal with some of the side effects that are going to be a little bit harder for them to go away. And the approach might be learning to live with some of the side effects instead of just saying they're going to go away, but how can we help patients enhance their tolerance and improve their quality of life while dealing with some of the common side effects associated with endocrine therapies. So we took a mindfulness approach in this study. Each of the group sessions is about an hour and a half long for 8 weeks, and participants who enroll in my guide, they meet online with a facilitator and they practice together for an hour and a half. So it's a little bit different than my guide, which is it's a self-guided app. In this case, women come together online. But they also have access to this great website with also information on symptom management, quality of life, understanding the benefits and utility of adhering to endocrine therapies, why they should be adhering to it, and then lots of behavioral reinforcements and strategies to complete their weekly mindfulness practices. And we upload recordings, guided meditation that they can go through and do on their own. And we were able to see all of their activity on the website. So we actually just started the trial, so I don't have any data on outcomes to show you. But so far, in addition to the hour and a half that women are spending doing their guided mindfulness practice, they're spending an additional 31 minutes per week on the My Journey website, reading content, downloading videos. So I think that's a good initial sign for the study in terms of feasibility and user satisfaction. And hopefully in a year or two, I'll have the data, and we'll see how it turns out in terms of facilitating adherence to endocrine therapy. So really quickly, as I wrap up, we also are my lab is looking at patient engagement in adverse event monitoring, and we have built the OncoTool platform, which helps conduct routine and remote symptom monitoring for patients who are a little bit more high risk. So these are all for patients in treatment with metastatic disease, and it's very similar to what Sophia was talking about, the importance of capturing patients' symptoms and especially toxicities. So this is an OncoTool platform that we developed, and it facilitates your patient-reported outcomes, and you can actually upload any type of questionnaire in here. You can do PROMIS, you can do Pro-CTCAE. You can basically tailor the platform to whatever symptoms you want your patients to fill out, and it will give the patients feedback on their symptoms, and the administrator too on the back end, the research staff, can also see that. And we actually have a paper on this that was featured in Cancer not too long ago. So the way the algorithm works, and we're actually testing this algorithm right now for patients initiating checkpoint inhibitors and for patients who are initiating a TKI or kinase inhibitor. The way the platform works is you can upload your patient-reported outcome, whether it's PROMIS, Pro-CTCAE, or any other questions assessing nausea, vomiting, fatigue, diarrhea, and then you can pick your algorithm based on whether your patient's initiating immunotherapy, kinase inhibitor, chemotherapy, and it adapts to whatever you want to assess for the patient, or whatever symptoms or adverse events are most prevalent for the treatment that your patients are going through. This is something I've worked with Sheetal with and other providers to kind of figure out what's the right algorithm for a patient initiating an immunotherapy. What's the right algorithm for patients initiating kinase inhibitors? And then let's test that out and see how we can monitor adverse events and improve quality of life. So we have 2 ongoing trials for this right now that we're just initiating as well. And that's it. Yes, 4 minutes to spare. I should acknowledge my collaborators, funding from the NCI, and thank you very much.